everyone, this is Yara Jalwan. I'm a preventive cardiology fellow at Hopkins, and we're all here at the ASPC, the annual meeting of the ASPC, the American Society of Preventive Cardiology in Boston. And I'm here with Dr. Bhatia, who is from UC San Diego, and we're here to ask him a few questions about his presentation and his opinions. My first question is, what's one risk factor people still underestimate, one cardiovascular risk factor?
Yeah, I think the big one that comes to mind is lipoprotein little a or LP little a. So LP little a, when it's at elevated levels, depending on how that's defined, can affect 1 in 5 individuals across the world. It's associated with multiple different cardiovascular diseases, including atherosclerotic cardiovascular disease and valvular disease, but less than 1% of people ever get tested. So a lot of people have this important risk factor and don't even know about it.
Yeah, and what do you think, who are the patients who should be tested for LP little a?
Sure, so this has been something that's evolving, but most international societies now are moving towards recommending universal screening, at least for all adults. So I fall in that camp of thinking that all adults should get it checked at least once. And that approach, I think, keeps it simple. We don't do a good job of testing as it is, so that way I think we would encourage further testing. So I would be an advocate for an approach of testing everyone once.
And do you think that's something that we should test every year, or?
Yeah, no, it's also a good question. Also an area of evolution, I think. In most people, LPA levels are quite stable over time, and particularly if you put people into buckets based on their risk. Most people will stay into those kind of, if they're low risk, they'll stay low risk usually. If they're high risk, usually they'll stay high risk. So in that case, most people don't need to be checked again. But there are people who can develop conditions that do affect LP little a later in life. Things like kidney disease, thyroid disease, menopause can raise LP little a levels. So particularly if someone has more of like a borderline level, then I do repeat it in the future. Another thing that's important is after someone has a cardiac event, like an MI, LPA levels can be affected by that acute inflammatory state. And so if someone kind of gets a check during a hospitalization, I usually will check that several months later after their hospitalization, just to ensure that we're getting an accurate picture.
Sounds good. And in case the LP little a is high, what are some therapies that you think are in the pipeline, or some emerging therapies that you're enthusiastic or optimistic about?
Yeah, great question. So there's a lot of enthusiasm about LP little a, particularly because of a lot of novel therapies that are in advanced stage clinical trials now. So the first is a drug called pelacarsen, which is an antisense oligonucleotide drug. So you see an RNA therapeutic that prevents the production of LP little a in the liver. That is now the subject of a large phase 3 trial, over 8,000 patients, that is projected to close early next year, hopefully. And so I think in the next year or so, we might have results from that trial. First trial, hopefully showing that LPA lowering reduces cardiovascular risk. And then there's several other drugs, including siRNA therapies, 3 siRNAs that are also in advanced stages of development that will be following closely after, and some oral options that are also undergoing development right now. And so there's a lot of, I think, potential, a lot that's going to be coming out in the next 1 to 5 years. But I think another thing that's important, and one of the barriers to testing, is that people don't often know that there are things that we think that we can do today to manage people's risk with high LP little a. So I still encourage people to get tested now, because we still kind of employ strategies to try to manage their risk as of now.
Excellent. And what do you think is the biggest myth? That's our final question. What do you think is the biggest myth about cardiovascular prevention?
The biggest myth about cardiovascular prevention, that's a big one. Well, I think in terms of LP little a, I could give specific to that. I think the biggest myth is there's no need to check it because there's nothing we can do about it. And I think we see that, 98, 99% of people never get it checked. And so that's a huge barrier right now. But we know at the minimum, LP little a increases risk. And so for multiple diseases, so at the least, you can be more precise about understanding someone's personal cardiovascular risk. And so that's important in guiding preventive therapies and preventive interventions. So we also know if you're very aggressive about traditional risk factor modification, things like a healthy diet, healthy, physical activity, managing the other cholesterol markers, especially the LDL cholesterol, we can reduce the risk. Lp(a) associated risk still remains, and there's a need to target that in the future, but we can mitigate the risk. And sometimes it guides which specific therapies we might use for LDL cholesterol lowering, might guide the use of antiplatelet therapies. It informs family risk because it is a genetic risk factor, and 90% of levels are determined by genetics. So there's a lot that we can do today to help inform and guide people's preventive efforts even before we have sort of these specific targeted therapies.
Excellent. Thank you so much. You heard it here first. We're at ASPC 2025 in Boston, and we just heard from Dr. Bhatia, the big Lp(a) expert. So thank you so much for your time.
Thank you. It was great.